Problem Gambling Services. This is Greta. We're going to go ahead and get started. Just to let you know, we are recording this webinar so that those that were unable to attend can listen in. And we'll also send out the PowerPoint and any handouts that we have to accompany this webinar after the webinar is over. So today, Roxanne Jones, our prevention coordinator, is in charge of moving our slides forward, so she is in charge of our webinar today, and I will be answering chats in the chat box as they come in. So next slide. So you can mute yourself if you want to, but we have muted everybody on this just so that we have a very good recording of this webinar. So when you do want to ask us a question, you can just type it in the question box or the chat box, and then we will either answer you or verbally or through writing. So we do have a presentation today, and we do ask that you hold all of your questions till the end, but you can actually ask the question at any time, but we won't answer them or have the presenter answer them until the end of her presentation. Next slide. Okay, so here's the agenda for today's webinar. We're going to start with some state updates. Then we're going to have a special presentation on older adults by Nirmala Dar, who is our Older Adult Service Coordinator here for our Health System Division, which is the new division that we now work for. And then we'll take questions and answers at the end of her presentation, for her or for Roxanne and myself also. Just to let you know, at the end of this presentation, you will receive an email that will have the PowerPoint and the company documents, because Nirmala does have a fact sheet she's going to be also providing us. And then you will also receive CEU certificates for attending. So that will come after the webinar, and just in case you're new to this webinar system, we know who is actually present, because the system that we use, the GoToMeeting, tells us that. So we don't take roles during this meeting just because it would be kind of difficult. So we know that who's on and who's not on. Next slide. Okay, so I just wanted to share with you that the PGS 5-year system improvement plan that we've been working on for over the last year will be finalized by the end of this week, and you will be able to find it on the Oregon PGS webpage at this webpage listed. And so it's been sent out in a draft form for comment and feedback, and now it doesn't have very many changes to it since getting that feedback from all of you. So if you want to view it in its final version, you can find it on the webpage. And we here, Roxanne and myself, will be working in the month of December and January to develop implementation plans from the different activities and suggestions within the implementation plan that was built at a very high level. Now we're going to get down more into the weeds about what we're going to do about each of these activities, and we will be sharing these implementation plans with you as they're developed for additional feedback and suggestions. So you will probably see in our next webinar, which I believe is in February, some of these plans being presented and feedback being asked for. Next slide. And I just wanted to cover a couple upcoming training opportunities. So we have the Focus on the Future Conference, which is going to be a collaborative conference between Washington State and Oregon this year. It is going to be in Portland in April. So I have provided you with the dates of the pre-conference workshops and then the general conference. And we should have registration open probably in February of next year. And we're currently working on the content of the conference, and hopefully can have more information to share with you in the next couple months about what you're going to see at this conference. So please mark your calendars to save the date for these dates just to hold them, and because we hope that all of our providers will be able to participate and attend. Also, just came across my desk yesterday is a webinar series being held by an organization up in Ontario, Canada. They are doing a webinar on social service providers' perspective on casino gambling and older adult clients. So they will be reporting out on a study that they did on older adults and casino gambling, and the perspective of the senior social service providers. So this ties in, I think, will tie in really well with today's presentation that Nirmala is going to present if you're looking for additional information, and this might help us better understand how to outreach to these senior social service providers. So I've provided you with the registration link, but I will also send out an email about this that will also include the link too, just as another heads up, so you don't always have to grab it from this actual PowerPoint. Next slide. So that was all the state updates, so now we'll have Roxanne give her prevention updates.
Thank you, Greta. So just a couple quick things. We have just a few boxes of the 2016 problem gambling awareness calendars left here at the Health Systems Division, ready to be shipped out to folks in the community. So if you are wanting to have calendars to distribute to your population that you're serving or out in the community, please connect with your problem gambling prevention coordinator for your county, and they will be able to get calendars out to you. Again, I believe at last count we have about 8 boxes left out of, and boxes have about 60 calendars in them, and we had at one point in time 10,000 calendars to ship. So we've sent out quite a few calendars so far. The other announcement is that for the Problem Gambling Prevention Connect call has been tentatively moved to the first Thursday of the month from 1:30 to 2:30 starting in January. This was based on a survey that had gone out. We switched to that date, but once we made that change, new information has come in that there are several people who that may not work for. So prevention coordinators be looking for a new survey to come out in the near future. And so this date is tentatively set for the first Thursday of the month moving forward, but more to come in that area. And that's really it for prevention. We're busy getting calendars out, gearing up for the new art search contest, and just doing the good work that everyone is doing out in the community. So more to come in the future.
Great, thanks, Roxanne. Can you go back one slide, please? All right, so now I'm just going to provide a few state treatment updates. So just a reminder that the January treatment call is January 6th from 3 to 4. The agenda and login information will be sent out probably next week. Just providing this as a reminder since the December one had been canceled due to this this all provider webinar. We didn't want to overload you with too many meetings in 1 month, so we'll restart again in January, so January 6th, so if you want to mark your calendars on that. And then I just wanted to remind you that don't forget that we are piloting a new performance-based contracting system this year, which is those 5 metrics that we've put out and have performance-based payments associated with. So that will end on December 31st, and when I mean that it ends, it means that that's what we're going to be looking at is July 1st through December 31st, 2015 data, and that's what we're going to base those performance metrics on this first round. We're going to base it on the 6 months. So just wanted you to be aware of that and make sure you get all your data in so that we that Herbert and Lewis and myself and our state staff have an accurate picture of what happened these last 6 months. And if you want any more information on those metrics, you can go to the website listed. Next slide, please. All right, so that was the end of the state updates. Very brief today, not a whole lot to say. A lot of good work going on out in the community and a lot of good work being done here by Roxanne and I. So if you have any questions, you can go ahead and type those into the chat and the question boxes and we will answer them. Otherwise, we are going to move forward to our special presentation by Nirmala Dar from our office here. So next slide, please. So I would just like to introduce Nirmala. She is our older adult behavioral health coordinator. She has worked for the addictions and mental health for, I'm not exactly sure, and she can correct me if I'm wrong, but for over a year. She has been part of our agency that Problem Gambling Services is under, and now in our new organization that we transitioned to, a new structure, she is actually in the same unit that Problem Gambling Services is. So we have, we're getting to have a more close working relationship, which is what kind of brought us together to have her come and present today. And she has a lot of great information to provide us on older adults and what's happening in the behavioral health system around them. So she's going to let us know about some new investments that the state has invested in through the legislature, and the role of these older adult behavioral specialists and how we might be able to collaborate and partner with them in the future. So welcome, Nirmala.
Well, thank you, Greta. Hi, I'm Nirmala, and I have been working for Health Systems Division, Oregon Health Authority, since February of this year, so coming on to 1 year. I am a licensed clinical social worker by profession, and for the last 18 years really worked as a clinician with Clackamas County in various roles, and had a lot of intersection and partnership with our problem gambling providers in Clackamas County. So I'm delighted to be here today. And I am actually very delighted to be on the same team now with Greta and a host of other folks. We were kind of split before this restructure. And I want to apologize, I have not amended my slides. It should read Health Systems Division instead of Addictions and Mental Health. So please ignore that. So the first part of my talk is not going to be a PowerPoint presentation, but I will be sending out fact sheets through Greta later. The second part I will be using a PowerPoint presentation to discuss what the roles of these new positions are, and hopefully you can go along with me. So, but just broadly speaking, before I really go into the specifics about this one investment, at the state level, I coordinate several older adult behavioral health programs. One of them is PASAR, which stands for Pre-Admission Screening and Resident Review, which is essentially a comprehensive mental health evaluation which is completed on all individuals entering a long-term care facility such as a licensed nursing home who have indicators of serious mental illness. So that is obviously a Oregon-wide statutory program. So that is one of the programs I kind of coordinate. And then there's another program which we coordinate at the state level, and the direct coordinator for that program is Lisa Peets, and that program is called Enhanced Care Services, which are one of the programs is Enhanced Care Facilities, where we have a joint partnership with APD, Aging and People with Disabilities, and Health Systems Division, where we have developed specialized programs in nursing facilities or in residential care facilities for individuals who have both significant medical comorbidities requiring nursing home level of care, but also have intensive behavioral health needs. Many of these individuals are transitioning from state hospital settings. So we have the enhanced care facility programs, and then we also have what we call ECHOs, or enhanced care outreach services, which are again mental health services delivered to individuals who are living in these kind of say assisted living facilities where they have both a behavioral health component and a nursing facility. So those are kind of the two major programs. And then obviously the program that I'm going to talk about is called the Older Adult Behavioral Health Investment. So the Oregon legislature made a significant investment in improving behavioral health services for older adults. So in the 2013 legislative session, funding was appropriated to the tune of $10 million to help through advocates, to really look at strengthening the behavioral health infrastructure of older adults across Oregon. Currently, I'm sure you're aware that every day 10,000 Americans turn 65. Every day since 2011, and this trend will continue till 2029 when the last of the baby boomers will turn 65. So this is a huge demographic shift. So by 2030, 1 in 5 Americans will be age 65 years and older, and this is obviously going to have a profound impact on our society, on social policy, and on our economics. In Oregon, currently 16% of our population is 65 years and older. It's a little higher than the national population. But some counties, for example, Coos and Curry and some of the Eastern Oregon counties, their county populations are 30% older adults. So it's variable across the 36 counties. So just some kind of national trends which have implications for behavioral health. 15 to 20% of older adults living in the community have depression, which often goes untreated or undertreated. This problem is much higher in nursing facilities, where close to 40 to 50% have a comorbid depression. Men aged 75 and older have one of the highest completed suicide rates across the country and in Oregon. Mostly white males. Then up to 15% of older adults are at-risk drinkers, and up to 23% deal with prescription drug misuse, often unintentional, but it's misuse. So what the legislature was looking at was really investing in strengthening services for older adults and people with younger people with disabilities in communities across Oregon. And at the heart of this investment, it was looking at increasing collaboration and coordination among agencies that really serve older adults, and making sure that people who care for them, such as clinicians, primary care providers, caregivers, even family members, are well trained or are competent in providing the kinds of care that older adults need today and will need in the future. One statistic I forgot to mention was that every 68 seconds, one individual is diagnosed with Alzheimer's disease or with dementia. So, and dementia is the 6th leading cause of death in America. So that is also a huge burden on our system. However, the investment that I'm going to speak about, the older adult behavioral health investment, is really geared towards treating depression and anxiety and suicide prevention among older adults. So as I mentioned, this investment was appropriated in 2013, and through a long process in working with our partners, it was decided that the investment would look at creating 25 positions across Oregon, which we are calling older adult behavioral health specialists. Each county, we looked at the population for each county, census data essentially, and looked at what percentage of the population was older adult, and we took older adult cutoff as age 65. Then based on that percentage, for every 30,000 individuals who are older adult in your community, translated to one FTE in terms of one older adult behavioral health specialist. So hence we have 24 specialists across Oregon, the 36 counties. Some of the counties have been regionalized. For example, all of Eastern Oregon is kind of one big region where we contract with GOBI, and GOBI stands for Greater Oregon Behavioral Health Incorporated. And the tri-county areas, Clackamas County, Multnomah County, and Washington County, which have high population density, have seven older adult behavioral health specialists. So it really was based on the percentage of population that were older adult. Part of this investment was allocated to a contract which we developed with Portland State University Institute of Aging, first to do what we called a needs assessment, and out of the needs assessment to really look at creating training modules. So Portland State University completed their needs assessment at the beginning of 2014, and these were really the results of the needs assessment. That systems were fragmented. Essentially, organizations such as then former AMH, aging services, primary care, all worked in silos with different funding priorities, eligibility requirements, and knowledge base. Secondly, behavioral health needs of older adults were not a priority for any agency, and existing services were not really tailored for older adults. Third, knowledge gaps were pervasive, including what is normal aging, available community resources, best practices in behavioral health. And lastly, resource and fundings are limited at best. Agencies are reluctant to fund services felt to be the responsibility of another agency, such as, hey, this is my turf, really he or she needs to be in your agency. So this kind of infighting or this internal tussle. So those were really the key problems that were identified, which was no big news to many of us who work in the older adult behavioral health field. Essentially, systems are fragmented. Behavioral health needs of older adults are not a priority. Knowledge gaps are pervasive, and resources and funding are limited. So to address this, really, this is how the investment unfolded, was to hire these 24 older adult behavioral health specialists in the field and one older adult behavioral health coordinator at the state level. And the one at the state level is my position. And I am happy to announce that as of this month, we do have 24 of our older adults hired across Oregon, and I will be happy to send the name and contact list to Greta at the end of this webinar for each one of you. These positions we have contracted with, for the most part, with community mental health programs across Oregon, and with a few regional entities like GOBI to really be responsible for the contracts in their respective counties or regions. We left it up to each county or region to to kind of figure out where they would like to actually physically place these positions. So these older adult specialists that I'm going to talk at length about later in terms of their role and function are co-located sometimes in aging and people with disability offices, in aging and disability resource centers. They could be co-located in behavioral health clinics. So we really left it up to each county to decide on that. And when you get the contact list, you are welcome to contact the older adult specialist in your community and find out from them, where they are co-located. Most of these specialists are qualified mental health professionals, so most of them come with in-depth clinical background, some related to geriatric or older adult behavioral health experience, some with more broader just behavioral health experience, and some are coming, one or two are coming more with an emphasis on systems thinking and systems work. But for the most part, they're going to be working in teams. So there are individuals who bring multiple strengths and experiences, both clinical and systems. Let me see. So the second half of the contract with Portland State University Institute of Aging. And by the way, the project manager for director is Dr. Diana White, who's a geriatrician, geriatric specialist, was to develop training modules for these specialists to use in their communities. So what PSU has done, they have created 8 training modules, which are, by the way, in the public domain, and I will send Greta the link. You are welcome to take a look at them. These modules were provided to the specialists for their feedback initially in several training sessions, and the modules are the training modules are, the first module is called the Everyday Experience of Aging, which really looks at kind of normal aging. What does it look like? The second module is Behavioral Health Partners in older adult behavioral health, and this is really geared towards what aging service providers need to know about the behavioral health system in Oregon. The third module is Aging Service Partners in older adult behavioral health. And this is the flip, really looking at what aging services partners need to know about behavioral health. The next 5 are really looking at clinical case vignettes, where they really promote a best practice of a interdisciplinary or using a multidisciplinary lens to really look at problems that older adults face. So the first clinical vignette in the module is What's Happening with Gladys, which really looks at anxiety and fear of falling in older adults. The second one is called Bill's Search for Lois, and this really focuses on clinical issues related to dementia, in this case to Parkinson's disease, and what are some resources available. The third one, the third clinical vignette is Has Anyone Seen George? This clinical vignette focuses on issues related to depression, grief, substance abuse, and social behavior, and it is really set in a rural setting. So it also looks at what are some of the issues in terms of access for timely behavioral health services in rural settings. The last clinical vignette is we have another call about NEL, which really focuses on schizophrenia and chronic health conditions. So those are the 4 clinical vignettes which were developed, and the very last or the 8th module looks at behavioral health issues and advanced care planning. So those are the 8 modules. We are hoping that the clinical older adult behavioral health specialists will partner with our community partners in really delivering these trainings to a wide variety of audiences in our community, including behavioral health specialists and our aging service partners. One of the primary targets or audiences of this of this investment are primary care providers, both physicians, family practice physicians, and nurse practitioners and physician assistants, and the entire team. Because we know that older adults, for the most part, the current cohort, seek their behavioral health they discuss their behavioral health issues with their primary care provider rather than come to a specialty behavioral health clinic. So we are the Institute of Aging is in the process of developing 5 modules which are specifically geared towards a primary care audience. So they will be shorter in content, no more than 15 or 20 minutes, and they have a little bit more of a medical focus. And the 2 that we did unveil are one was on anxiety, one on substance abuse, and I know what's under development is one is on depression, and one is on suicide in primary care setting. So we are hoping to use those modules in engaging our primary care partners. In addition to these 8 training modules and the 5 training modules for primary care providers, in the Institute of Aging, Portland State University also looked at helping these specialists in developing their own capacity to deliver these services, and so we held 3 what we called capacity building learning sessions, where we helped the older adult specialists really look at the tools and nuts and bolts of developing capacity in their community. For example, we held a session on helping them identify stakeholders. How do you identify who are your stakeholders in your community? How do you conduct stakeholder interviews? What are some good tools that you can use to collect data in terms of capacity building? We looked at some of the later sessions looked at some basic quality improvement tools or tools at promoting collaboration among multiple sectors. So we had 3 capacity building learning sessions which I know have been very, very helpful for the specialists. What we developed was a framework for community capacity building, and these were the kind of the components of that capacity building model. The first component was a process for identifying gaps and issues and addressing them. The second component, direct service staff have increased their knowledge levels about older adult behavioral health. The third component, direct service staff are using best practices to screen, assess, and treat older adults with behavioral health needs. The next component, evidence-based programs are being implemented across Oregon. The next component, the needs, preferences, and opinions of consumers, family members, and advocacy groups are included in planning and delivery of services. And the last component, the coordination of services among stakeholders is improving. So those are the kind of the components of our capacity building efforts. In addition, what I have developed, and it will become more clear after I discuss when you look at the PowerPoint about the role and functions of the position, we have also developed what I call a performance metrics report. And I heard Greta refer earlier to kind of some pay for performance metrics that you all are using in your contracting. This is, however, just a quarterly report that specialists report back to me on, aside from the financial that they report on. And again, the metrics or indicators were developed directly from their job functions, and they cover three main areas. One is coordination and collaboration. The second is complex case consultation and promotion of best practices, and the third one is capacity building. So I have actually developed a performance metric report with very clear indicators which they will be reporting on quarterly, and we did receive our first quarterly report about 4 weeks ago. In addition, we are also looking at I'm looking at developing on what I call a roadmap, where each quarter, where the remaining 6 quarters of this biennium, there will be very clear indicators or benchmarks of what needs to be accomplished in each quarter to kind of really see that we are hitting all the targets of this investment and that we have some really good outcomes to report back to the legislature. Let me see, what else can I tell you generally about the program? Essentially, what I am seeing in terms of just my own role briefly here at OHA and in the community for the past 18 years, that really the knowledge gaps are pervasive in terms of what are best practices for older adults, and coordination among partners is minimal, especially primary care and behavioral health. I know there's this whole movement to move towards integrated care, where you're providing behavioral health, primary care, and dental care all in one setting. That's certainly a movement in the right direction, but often primary care practices do not have the specialized knowledge or just knowledge and awareness about what are some best practices for older adults. So I can just briefly tell you about some of the best practices. I'm not going to go in depth. In terms of, and I can send those links. I think it would be better if I send those links to Greta for distribution. There are specific best practices for depression for older adults, which really focus on behavioral activation and problem solving. One of the best practices is PEARLS, which is coming out of the University of Washington, and which was tested in terms of a random control trial with older adults, and has been adopted by some of the ADRCs. I'm not sure how many of you are aware of ADRCs. ADRC stands for Aging and Resource Connection. This is a kind of a hub for aging services, and there are 9 across Oregon, and if you go to the DHS website and just put in ADRCs, Google, or just put in ADRC in the search box, you will, and it should be all uppercase ADRC, you will see a map, you will see a map with all of the regions, and I would certainly suggest that you connect with your local ADRC to let them know about problem gambling services, because they are often disseminating information, and they also collect information in terms of a directory, web-based directory. So I would certainly urge you to connect with them in your particular region. As I said, there are 9 ADRCs across Oregon. They are actually a program out of aging and people with disabilities. However, they also have, many of them have adopted what they are calling mental health or promotion programs. And some of the mental health promotion programs are really looking at community-based depression programs, whether they are led by a clinician, like I was saying about pearls, or really really looking at promising practices where they are using peers to deliver depression care. So that is also happening across Oregon. There is also another website which is again a kind of a joint venture with our aging service partners, APD, and I would certainly suggest that you keep that in your back pocket as a training resource that you can share with people who are looking for training on, say, dementia or on complex behavior issues or on medication management. And this is free, and it is OregonCarePartners.com. And again, I will send this information to Greta. Please go online and check that out. These are free online trainings, and actually CEUs are also provided in terms of contact with individuals that you may, the contact you may have with individuals. Before I move on to really talking about the role of the older adult, I want to also briefly talk about part of this investment looks at raising the community's awareness or the mental health literacy of communities regarding behavioral health issues of older adults. And a big thrust really is to promote mental health literacy and to promote wellness and prevention. And one example I give is regarding social engagement. We know that older adults or even younger adults who are socially engaged, it is a protective against depression. And so a big part of our investment is really looking at how can our communities really promote health and wellness in terms of preventing depression. And I can see a big role in terms of partnering with you guys, because really social isolation often is a big reason for older adults seeking out, maybe seeking out gambling venues because of its social component, and often it then developing into a problem. So a big part of our investment really looks at promoting health and wellness in terms of looking at what factors are protective against depression and anxiety in older adults. With that in mind, again, the Institute of Aging has developed some models specifically addressing issues. One issue is addressing social engagement. There's one module looking at substance misuse, and there will be one on, I think, on anxiety and also on suicide prevention. So again, I can't emphasize again, the findings in the needs assessment about how fragmented our systems are in terms of in terms of working with older adults, and also the knowledge gaps, how pervasive the knowledge gaps are. For example, I've worked in the behavioral health field for 30 years, and I still don't completely understand what eligibility criteria our aging service partners use to make people eligible for older adult aging services in their, in their system. Or or looking at what are some standardized screening tools which have been normed for older adults, say, that we can use with some confidence, offer some reliability in primary care or in behavioral health settings. So those knowledge gaps are really very pervasive. And of course, ongoing struggle with resources and funding in terms of priority. What the report shows, that a priority is generally in our mental health systems, through health systems. Generally, the priority is on younger populations with serious mental illness. So often older adults are left behind. And with the demographic shift that I emphasized, with us moving towards 1 in 5 Americans and 1 in 5 Oregonians being an older adult in the very near future, it is imperative that we look at these issues and try to kind of fill those service delivery gaps and really highlight the need for older adult behavioral health services throughout our service delivery system. So with that said, I'd like to talk very briefly about the older adult behavioral health specialist role and how perhaps you can partner with them in your communities. So Roxanne, I'm wondering if you can forward the slide. So there are 3 primary functions of these roles. Like I said, there are 24 across Oregon, across the 36 counties, and 2 of them are regionalized. Much of Eastern Oregon, there are 4 specialists, and then Central Oregon, which are 3 counties, which are kind of regionalized, there are 2. Otherwise, most counties have 1, 2, or 3 specialists. The 3 functions are interagency, multi-system, cross-sector planning for better coordination among systems, complex case consultation, and workforce development and community health and wellness promotion. So those are the 3 primary functions of these positions. Next slide, please. This was my conceptualization, where the triple aim really is at the intersection of these 3 circles, which is better health, better care, and hopefully over time lower cost through the use of these positions. Next slide. So I'd like to talk briefly on the first function of this role, and I would say this is really the primary function. It's really the impetus for these positions to be here, and the results we want to see is really promoting coordination among these cross sectors, multi-sectors that really touch the lives of older adults. So it is really to promote partnerships and linkages, promoting the value of collaboration, and building a common culture and values of collaboration and coordination. And we are hoping if this happens, the process would result in the removal of silos, aging services, behavioral health, public health, primary care, that we would really remove these silos. We would strengthen the commitment of partners towards this more holistic, collaborative approach. We would eliminate barriers. We would overcome pushback by building trust and support. we would really create synergies. We would have an alignment of our goals where we would really all be looking at a very person-centered approach. And lastly, that we would really have a framework of finding solutions. So I know it's a, it's a tall order, but that's really at the heart of this position, is really promoting coordination and collaboration within their communities among these multiple sectors. Next slide. So the results of better coordination would be a responsive service delivery system where we have a client-centered approach. It would reduce costs. It would certainly reduce redundancy in services. And it would, we hope, reduce situations where clients fall through the crack. And I'm sure we all know of clients who fall through the cracks, where every system says, he's not mine, she's not mine, and they kind of get bounced around, and what happens is they receive poor care, we have poor health outcomes, and we have increased health expenditure. Our hope is to ensure coordinated planning, development, and implementations of policies, programs, and services. At its best, and this is visionary, enhanced collaboration and coordination would lead to the creation of a whole person's seamless integrated system of care, where the client is at the center of any kind of planning rather than the system. Currently, the system is at the center. It could be, health systems, it could be addiction systems, it could be, it could be aging service systems. And then we try to make the client's needs fit our system. So our vision is the other way around, where it would be really client-centered, and we would try to see what can each system contribute to the success of this individual. Next slide, please. So what are the benefits of enhanced coordination of systems? Better use of resources and expertise. And I can't emphasize this enough. When I worked for Clackamas County, I was the geriatric mental health specialist for about 14 years there. And a big part of my role was really working very closely with our aging service partners. And I can tell you how beneficial that was both ways, where my expertise in behavioral health was used in terms of case consultation, and their knowledge about aging service systems was used to my benefit, and I was able to take that information to my entire behavioral health system. And we are hoping that these positions will foster that. Better infrastructure to serve seniors. A big part of the big part of capacity building is really to do this continuous needs assessment, to look at where are the gaps in services. Where do we really need to either strengthen the infrastructure or really actually develop it because it doesn't exist? For example, I'm hearing increasingly, a lack of behavioral health providers in, say, rural settings. What can we do to develop our infrastructure? And we are looking at telehealth as an option. The other would be the dearth of Medicare providers. For various reasons, poor reimbursement rates, limited providers in terms of licensure requirements. So those are some of the issues which are coming to the fore in our ongoing needs assessment. And part of the needs assessment is also then looking at where do we really need to plug in and do some quality improvement kind of projects. The other one would be reduces stigma around seniors. So we are hoping to look at where would be the best place or a process to provide behavioral health services for older adults, especially the current cohort, which would be least stigmatizing, and obviously it is the primary care setting. And better case finding, and which would result in increase in referrals. Again, that would all come about through coordination, through a coordinated effort. Next slide, please. And these were, this talk was initially geared towards our older adult specialists. So I was suggesting some activities, and many in the first 6 months, many of these have already taken place. Building, doing impact assessments, doing focus groups, strengthening partnerships through formal memorandums of agreement or even informal partnerships, conducting formal needs assessments, looking at how to build cross-system coalitions, and collaborative program developments. Next slide. So the second job function or role is consultation. Most of these specialists are qualified mental health professionals, QMHPs. So they're coming with a background in behavioral health, many of them with a specialty in older adult behavioral health, and some may not have in-depth knowledge about older adult behavioral health, but certainly can tap into those resources. So one of their functions is complex case consultation, where really the goal is to have a multidisciplinary team approach to complex case consultation, which would involve aging service partners such as case managers from aging services, behavioral health people if they're involved, some primary care physicians, nurse practitioners, physician assistants, and anyone else who touches the lives of older adults, to really also adopt a multi-morbidity lens. Many older adults have 2 to 4 chronic conditions which impact their behavioral health, such as arthritis, cardiovascular disease, diabetes mellitus, just name it. So adopting that kind of multi-morbidity lens, really consulting on individuals who have that cross-system need. They have significant behavioral health needs, they may have significant aging services needs, they may have primary care, chronic medical needs. Really looking very closely at social factors or social determinants of health, and really having this kind of solution-focused approach. Next slide. I think you jumped one. One more. Could you go one more back? I'm not sure. Okay, yeah, the next one. So the task that the specialists have at hand is to really create these MDTs or multidisciplinary teams. Some counties already have them, so they are kind of just enhancing those teams. Some they are creating it from scratch. So if it's not an MDT, actually creating some forum for complex case consultation, and then providing technical assistance to systems that work with older adults. In addition, we are hoping that these sessions or these MDTs or these complex case consultation platforms also promote best practices. So, for example, if they are consulting on a client who has significant depression, and also has other issues, which involve different sectors, that these specialists would be also promoting what are the best practices for depression care for older adults. So they would take that opportunity to also promote best practices or evidence-based practices, and also obviously highlight and illustrate coordination, which is what this is all about. So I'm glad to say that most counties now at least have the beginnings of a multidisciplinary team process. And, it may behoove all of you to maybe connect and find out, when these happen, if you would like to be involved in them. Next slide. These were, so the third big important function, I think, is workforce development and community education and awareness. In terms of workforce development, is really increasing the human capital infrastructure through a range of activities that would create, sustain, and retain a viable and competent workforce. What we have found across Oregon in our needs assessment, and which was no big news, is really a lack of trained professionals, paraprofessionals, caregivers who really understand behavioral health of older adults. Next slide. So in terms of community awareness and education, using a population health lens, as many of our specialists are really coming out of community mental health programs where they had a much more narrower lens, where it was more individual based, but this is really looking at the entire older adult population in their counties. And then looking at how do we increase the mental health literacy of our communities in terms of serving the needs of older adults, behavioral health needs. How do we promote protective factors at a community planning level to prevent, say, depression, or in your case, problem gambling? Or how can communities create greater opportunities for social and civic engagement of older adults? Remember, I told you every day 10,000 older adults are turning 65, and these are more younger, healthy older adults coming to retirement age. How can we engage them? What are some civic engagement activities that we should be looking at planning at a community level? Productive engagement can lead to multiple positive ends, including positive health outcomes. So really looking at this huge wave of older adults who are coming into our communities as retired persons, how can we use them? What do we need to do in terms of planning to really look at a civic engagement and opportunities for volunteering as really protective against depression and anxiety? Next slide, please. So some of the core tasks for this third function are advancing and promoting best practices, and that could partly be through the use of those modules that I talked about earlier, developed by PSU. It also could be really arranging for trainings, aside from the modules, for a broad swath of providers of health services for older adults, and really promoting best practices. For example, what are some evidence-based screening tools that can be used, say, in primary care settings, whether it's the PHQ-9 or it is geriatric depression scale, or MAST-G for alcohol, screening for alcohol misuse, or the audit. So really promoting that. There are many other tools that we would like to promote, which I just want to highlight for a moment. One, in terms of older adults, one is really, I don't know how many of you know of the BEARS criteria, which really is a list, BEERS, BEARS criteria. A new one came out in 2015, which really looks at what are some medications which are contraindicated for older adults, whether in terms of just prescribing it, or the prescribing dosage, or the drug-to-drug interaction. Our hope is that by the end of next year, at least 50% of primary care practices will know about the Beers criteria. So that's one best practice we want to promote. The other one is really promoting the evaluation of baseline cognition for most older adults who come into primary care settings. So the use of standardized instruments such as SLUMS and MoCA to screen for neurocognitive issues. We also want to look at falls prevention, really screening for falls. So we want to partner with our public health partners in really promoting for ongoing screening for falls prevention. And often I get the question, how is falls prevention in any way connected to behavioral health? Well, it's protective against depression, because do you know that if you fall if you're 80 years and older and have a fall, it's kind of considered a terminal event, and that it kind of limits your ability to it limits obviously your ability for mobility, and then also isolates you and often results in death. So really looking at preventing falls is very much a best practice. So those are, for example, some of the best practices that we will be promoting. Then facilitate implementation of evidence-based practices. So we are hoping to really work with our primary care audience and also with both our aging service and behavioral health partners in really looking at implementing these. So not just promoting them, but really looking at how can you develop a quality improvement process where you're implementing some of these best practices that we are advocating for. Really looking at community assessments. I know most communities do a community health assessment, and if you haven't already looked at yours, please go online and look at them. And if you'll see, almost all the community health assessments have identified mental health as one of their top 5. So really having this ongoing conversation with your community and contributing to the community assessment. Very importantly, really promoting health and wellness, both upstream in terms of policies and programs, and also downstream. So really providing that education to the community stakeholders who plan community and wellness programs. And then lastly, a productive capacity of older adults, looking at developing programs that really use the productive capacity of this wave of older adults who are retiring for 2 reasons. One, it's protective against depression, a meaningful activity and volunteerism. In fact, there was a great article through a peer-reviewed journal which showed that volunteering actually increased longevity. So whether the motivation was intrinsic or reciprocal, the end result was that it increased longevity and also had produced better health outcomes. So really looking at how can we utilize our older adults. So first was in a productive manner to be a protection against depression, but also how can we use this cohort of new retirees who come with a wealth of experience, both professional and paraprofessional, to really use them as peers in delivering in delivering behavioral health services to people in the community who are either having subsyndromal depression or anxiety. Next slide, please. Next slide. So these were some of the suggested activities I had for them. You know, conducting brown bag luncheons for behavioral health and aging service staffs. It could be even for senior center staff. It could be for primary care. You can put anything. And you know, these are no costs. This is no cost to anyone to conduct a brown bag luncheon. We have the training modules, webinars such as you know, like one they were doing now, breakfast meetings. And we are looking to really engage primary care providers at breakfast meeting or at their team or at their kind of monthly medical team meetings. Adopting and implementing mental health first aid for older adults across Oregon. And you do know that there is now a mental health first aid has come out with a special older adult module. And many of, at least 4 or 5 of our older adult specialists have become certified in mental health first aid for older adults. So we are looking at disseminating this mental health first aid for older adults across Oregon, partnering with our public health partners in, say, falls prevention and SBIRD adoption. And then other one, we are looking closely at how can we kind of dovetail or really kind of leverage some of these, you know, special events that happen as like the National Depression Screening Day, or there's a whole month about awareness. How can we kind of leverage that to really extend our message and agenda about behavioral health of older adults? And one of them was really looking at, can we make National Depression Screening Day a big thing as part of our investment? Next slide. A big focus is on really collecting data, both qualitative and quantitative. And I told you, you know, partly we are collecting it through the metrics report, you know, which they have to submit quarterly across all 3 job functions. And by the way, the metric reports cover these 3 job functions. Currently, most of the indicators are process indicators, because we are hoping that these process indicators would be proxies for outcomes. And the purpose for collecting data is not just collecting data for data's sake, but it's really that the data would catalyze change. It would help us look at areas for improvement, and long term, we're looking obviously at outcomes. Next slide, please. You know, as I mentioned, these are brand new positions. They have only been in existence for about 6 months. So needless to say, there was, you know, some degree of angst among many of the older adult specialists. And I keep telling them there is really no blueprint for these positions. We are co-creating them in terms, we have a broad framework and we have a charge from the legislature, you know, what we need to accomplish, but really the positions are new, and we are, you know, we are developing them as we go along. So I kind of encouraged the older adult behavioral health specialists to acquire this mindset. One was of optimism. The other one was really of creative confidence. The third was tolerance of ambiguity, which for a lot of them is has been, you know, difficult. Immersion, just immerse yourself in your communities and in the needs of older adults to better understand what's out there. Learning from failure, and that we are going to iterate. You know, each new product or area we think we want to improve, you know, it's okay to go ahead and make those changes and then learn from it if it didn't work, or how can we improve it for the next time round. So we keep referring back to this mindset because it's very important for the 24 specialists to know that these would be some key things or traits that they need to keep in their back pocket as they go about their daily work. Next slide, please. And that is it. Thank you for having me, and I'd be very happy to take questions. I know earlier I had some brief conversations with Greta and a few other people, and I had asked about the prevalence of gambling, problem gambling, older adults. And if I recall, Greta sent me some information, and I think it's within the range of about 1.3 or 1.5% older adults. I am sure that percentage will certainly increase exponentially as the population, as the demographic changes occur over time. So with the prevalence rate at where it is, it was very interesting to see the webinar that Greta referred to, that is coming up from Canada about the casinos and older adults, because social isolation is a huge factor in the lives of our older adults. And gambling and casinos often serve that function of social engagement, interaction with others, and easy access, because they make it easy for older adults in terms of providing transportation. So it will be interesting if, I don't know, whether you'll keep specific data about age groups, which age groups you are seeing at greatest risk. I would say individuals who are more single, recently widowed, and all would be at greater risk. Those who are going through those kind of transitions where social isolation plays a significant factor, as it does in suicide and completed suicide. I would be very interested in looking at that long term, and whether y'all have anything specifically designed in your program development for, or adapted for, older adults. With that said, I'll keep quiet and see if there are any questions, and I will pass this on now to Greta and Roxanne. Thank you again for having me.
Thank you, Nirmala. That was a very informative presentation, and I think that from that presentation we know that there is with the older adults in the communities that we could definitely help with their function of the coordination, and that I think that we have a lot of information that we could share with those community older adult coordinators regarding the services that we provide, and helping them make that referral source and that identification within the clients that they see, and that the older adult specialists in the community probably have a lot to offer to our providers on how to outreach and reach this older adult population with methods. And also just on the treatment side, I think it's really important if we start to see this population come through our doors more frequently, we need to have a better understanding of how does treatment possibly differ for this particular population, as their cognitive functioning can be different than the general population. And so I think that we have this could be a really great partnership and coordination to sharing information. So thank you for that presentation, and I will definitely keep you informed on the data that we collect through our program. I feel like just here at our own office, I feel like we're going to have a better collaborative partnership between our two programs. So I'm really looking forward to that.
Thank you.
So if you have any questions for Nirmala, please type them in your chat box and I can read those to her for her to answer. Or if you have any questions for Roxanne and I too. Right now I don't see any questions in our chat box. But Nirmala's information, contact information is on the screen. So do feel free to contact her if you have some specific questions. I know that Philip from Cascadia up in the Multnomah County area has reached out to Nirmala on a specific project that he's working on with older adults. So Nirmala is very open and available to help us in moving our system forward to serve this population. So I'm just waiting to see if we have any questions. And like we said, we'll be distributing this PowerPoint along with a fact sheet that Nirmala was going off of during much of the beginning of her presentation. That's where her facts had come from. So you'll have that fact sheet that explains facts on the older adult population and also a little bit more information on the investments that we received and how that program was designed.
I will also send you the list of the contact information for the older adult specialists in each county or region.
Oh, that would be great. Thank you.
Mm-hmm.
Okay. So
looks like I did an outstanding job, but we have no questions.
All right. Well, let's just go on to the next slide. I think the next slide was just questions and contacts for our office. Okay, next slide after that. All right, so there's the contacts for our program. And I think that's about the end of our presentation. So if you do have any questions, feel free to reach out to Nirmala directly, or if you feel more comfortable, you can send your questions through me and I can forward those on to Nirmala or find out the answer for you, whatever works for you. Otherwise, I will just go ahead and let you guys go a little bit early. I know I appreciate all of you hanging in there through this 90-minute webinar. I hope that you found it very informative, and I hope that you have a good rest of the remaining week. So all the accompanying documents will be sent to you early, by the end of this week or early next week. So once again, thank you, and keep up all the good work that you're doing out there in the community. Have a great day. Bye.
Thank you.